Hello, my name is Dustin Anderson, and I'm going to be talking about my clinical reflection today. Um, Coming into holistic healthcare too, I really didn't know what to expect. Some of the information, that we went over, I felt like I knew, but I knew there was a greater purpose for the class, and it wasn't sort of, it was to get us to think about why we do the things clinically that we do, not so much to change how we do clinical practice, but to make us think about clinical practice. And I think I picked up on that fairly quickly because I've done it in the past myself on my own. Um, I've been a clinician for 4.5 years, and when I got out of school, I was really worried about getting the pathology right, making sure I had the right diagnosis, right treatment. I know when I say that it's going to sound bad, be like, well, duh, that's what you got to do as a clinician is to make sure that you get the pathology right, get the treatment right, get the athlete or the patient back to where they need to be. Yes, that's a chunk of what we do. I would say that's like 70% of what we do is finding out what's wrong, making sure we're doing the right thing and getting the person back. But there's also other dynamics that I think clinicians don't really, I shouldn't say don't really, but may not think about fully. And that's how the patient feels about the treatment, how the patient feels about being injured. And for me, it took me a long time to really let that sink in. I was under the mindset of I'm the clinician. I went to school for this. Believe what I said. Believe what I say. It's sort of like my word's law. Why aren't you following it? And when I started getting the patient involved in care, as far as a sort of asking them how they felt about it, what was going on, because as clinicians we don't know how it feels within their body. Pain's so subjective that we got to know what they're feeling. And another thing that we did in class that I really liked was the clinical prediction rules, the diagnostic algorithms, the treatment algorithms. I think it's important as clinicians that we look at the epidemiology of the sport, the population that we're covering. It was a Cosmo episode. Neil deGrasse Tyson said it pretty well. Our ancestors looked up in the sky and they were able to recognize patterns in the sky, and they could say, "Hey, around this time, seasons are going to change," or if they were on a ship at night, we need to go this way because of this. And I sort of think that's what clinical prediction rules is. What clinical prediction rules are. It's a way to recognize patterns in the population that you're working with. We learned in class for say for auto ankle rolls to be valid and reliable across the board. You have to do it. It has to be so across a wide spectrum of patients. But I think clinicians get bogged down into saying, hey, it's not law per se, but you can definitely take what you've learned from the research and apply it to your setting. Just because it's not published and accepted widely doesn't mean that you've not read the research, you don't know your population, and that you cannot make those rules yourself. For me, it took me a while to realize that. And I have diagnostic and treatment algorithms that I just use specifically for my setting, which is the military. I've worked with the military for 2.5 years. And there's things that I've done that I've started saying, hey, they're getting back quicker with this one. Hey, I picked up on that pathology quicker by following these roads. And it also, I think, it puts a standard of care across the board. That it's not so much an end-all be-all, it's just the start of the road. It's to get you started. And if you're having trouble figuring out what it is, you can go down that path that you know that has worked in the past or that's been shown to work. And it's an ever-evolving process. I think as clinicians, we shouldn't stop thinking and questioning what we do. And it all starts with the question of Why is it happening? Why is it happening to my population? How can I fix it? What's the research out there? Do I need to try to get it, talk to an expert in that profession? If you can't talk to an expert, talk to your colleagues. Talk to some teachers from the past. You have the tools. You've just got to be able to think through it and think a little bit bigger than just that individual patient. Think about your patient population. How's it going to impact them moving forward? And working with the military, I only get, maybe working with basic training now, I only get 9 weeks to work with these individuals. When I was at Fort Benning, depending on what school it was, like if I was with MCCC, I could have up to 6 months. IBOLC 17 weeks, OCS 13 weeks. And I think that time limit, that time crunch helped me evolve my understanding and my willingness to put in clinical prediction rules or diagnostic and treatment algorithms, because you got to put in what works and the best available evidence out there, because if you don't, I think you're doing a disservice to your population. I know there's a lot of clinicians that may disagree with me, but for myself, I've seen it work. A good example is I had a lot of people coming in when I was working at Fort Benning. I had a lot of people coming in after ruck marches with swelling over the cuboid. Never really knew. I remember going over cuboid syndrome when I was an undergrad, but I picked up on this pattern. Like I said earlier, we're programmed to pick up on patterns, and it was usually after they had a long ruck. It wasn't after they rolled an ankle. It was after they walked 10 kilometers, 12 kilometers. And I did my research. I started looking around, like, okay, what do I need to do for this? And I developed a system of dealing with that type of pathology. Did it work all the time? No. Did it work the majority of the time? Yes. And I was able to get people back quicker, and people were happy with what I was doing. I could actually say, hey, this is why I'm doing this. This is what I've read. This is who I've talked to. This is how it's worked in the past. I think as clinicians, we should always question what we're doing, why we're doing it, what's the best way to do it, and always talk to each other and just keep evolving from there. Bye.